I've been given the task of trying to summarize what we've heard so far while also getting you to lunch. So let me try summarizing by saying that I think the discussions very much remind me of a quote by Francis Moore, the former chairman of surgery at my hospital in the 1940s. And what he wrote at that time, I think fundamentally speaks to what is happening here. He said that the fundamental act of surgical care is the assumption of responsibility. What this commission and these commissioners have done is a fundamental act of assumption of responsibility that I think we as a community have individually sometimes taken seriously, but may finally be taken seriously at a broad level. The incredible challenge of writing this report, and I remember being at the first commission meeting, the incredible challenge of putting the report together was to try to answer a very fundamental question. And it's the same question we have when we see a patient. What is the problem, and what can we do? And asking and trying to sum up at the end of that first day, it was very unclear. My question to the team was, can we answer at the end of this, if you were given $1 billion, what would you do? And I don't think there's quite the, okay, put it in this bank account and we'll take care of it and it'll be solved right there. But this report has taken us an incredible way. The second aspect of understanding what we are hearing, I think, is that it reminds me that one of the places I've come to think is the most difficult moment of surgical decision-making and communication is the moment when you have an emergency patient, you have to decide whether to take care of surgically and what you are going to do, and it's an elderly patient or someone who's chronically ill. And what you're attempting to do in that, time is short, you have a limited window, and you need to do many things at once that are extremely hard to do. And this is what this commission was attempting to do. You need to, with that patient, gather the evidence and assess. You need to have a bad news conversation. You need to have a discussion about goals, what goals that person really has for their life. You have to discuss the options, and you have to come to a decision. It is extremely difficult to pull off just with your patient, and I would say it is the same here. But I think we have come, in the course of these discussions, an incredibly long way for this patient. The first is understanding what the problem is. And I think at a very broad level, this commission has redefined global health. Global health is, to me, the concept of delivering on the knowledge that we've discovered over the last century about how to take care of people and assuring that it's delivered everywhere, not just in the poorest of the poor places, not just infectious diseases. It is all the knowledge that we have discovered over the last century, and it is everywhere in the low income, middle income, and high income parts of the world. And I think this group as a whole has taken that focus from global surgery and really helped redefine and fundamentally make clear that that is what global health is. What they have demonstrated is something that I think people don't understand, which is that surgery is not a luxury. We have, in the course of the last century, identified for our 13 organ systems in the human body, 60,000 different ways that the human body can fail. 60,000 different diagnoses and conditions that the human body has. In the course of this last century, we have discovered 4,000 medical and surgical procedures that can make people's lives better, if not cure them, relieve their suffering, reduce their disability. We have also discovered more than 6,000 drugs. We have discovered hundreds, if not thousands, of approaches to prevention. And our job has become to deploy that capability town by town to everybody alive. It is an unbelievably difficult job. And it's not surprising that no one has found the answers to how to do it all. But it's clarity about the goal to begin with. And I think out of that clarity has come, for me, the most critical key message, which is that surgery is an indivisible, indispensable part of healthcare. It is essential. It is an essential component of living a long and healthy life. Very few people escape the need for surgical care in the course of their lives. How many of you, thus far, have required a surgical procedure in your life? Okay. Well, now put in context that there are 5 billion people, well-modeled and well-characterized, who cannot access safe surgery when needed. That is 5 billion out of the 7 billion people on Earth. That is taking 5/7 of the people in this room and then imagining that capability was not there for you when you needed it. That when that 2 billion got it, 1 in 4 went through a financial catastrophe, wiping out 40% of their income. I was lucky enough to be part of the Disease Control Priorities 3rd edition project with many of you here. And I think one of the things that is critical to the demonstration of what we can do is that they found that 44 procedures are as cost-effective as many of the basics of public health. Oral rehydration therapy, ARV treatment for HIV, many vaccines. We're talking about treatments that provide, that are less than $100 per dally. There are 3, I think the identification by the Commission of a very practical understanding of how to get a hold and grasp what a surgical system is, and that explaining that it is a system that can deliver on the 3 bellwether procedures of C-section, laparotomy, and open fracture, and that it brings along with it those 44 procedures that are of such human worth and many others that come along with it. I think the last panel helping make it clear that it's achieving a very crisp goal of 20 to 40 surgeons, anesthetists, and obstetricians per 100,000 population, that is what is life-saving and climbs up that curve. And then finally, to begin to answer, I think that the last couple of people who raised questions, I think hit it perfectly when they said, how do you convince the governments? What is it that you need to be able to do? And I think some of that evidence was starting to be here. You know, when they described that 40 billion could close a gap over the next 15 years, and that it would avert $12 trillion in lost GDP for the world. A quick back-of-the-envelope calculation is that for every dollar we put in, we're returning $300 in economic growth. And that is not 10 years from now. When you saved a worker's broken leg so they can continue to walk, when you saved a child and mother in an emergency delivery, these are immediate economic effects that we have begun to have a glimpse of. Richard Horton prevailed upon us to understand that there is a fundamental transition, and it is a transition to accountability, and that the power of an independent force of people who hold the world accountable to its commitments and to its potential is a fundamental part of what we can do. But I think that what we were hearing towards the end was an exhortation to go one step farther, which is to take that fundamental act of surgical care, which is an assumption of responsibility, or responsibility to improve these numbers. Yes, part of that is by holding accountable, but part of that is going to be by many of you here who are going to create those models that make improvements along these measures actually feasible. I think the afternoon is going to be forced, whether they like it or not, to be able to grapple with what are the options. By the end, we're hearing some of that, okay, we get it. We get it. This is serious. We understand where the goals are. Now, what can we do? I think a very important set of discussions to follow will, for example, be on the financial implications of what we know, and also what financing means along the way. What I will summarize then, or say here, is just to complete the quote from Francis Moore. Surgery has assumed responsibility for disease which is largely acute, local, or traumatic. This is responsibility for the entire range of injuries and wounds, local infections, benign and malignant tumors, as well as a large fraction of those pathologic processes and anomalies which are localized in the organs of the body. The study of surgical care is the study of these diseases, the conditions, and the details of care. What we've begun to describe are the details of care. The surgical mind wants to know the steps, and that is the direction that I think we now can push forward to, having laid out the goal. Much more to come this afternoon. I'm looking forward to hearing it. There will be lunch outside here, but also a modeling seminar going on in here for those of you who want to know how this information was modeled, and perhaps how you too can create models to solve these problems. Thank you.